Great. If we could get all the presenters up to the stage, we can have a little discussion. Are there questions from the audience? Please don't be shy. This is your opportunity to ask questions from all of these amazing surgeons.
It's the lifestyle.
So I'll start with the question for Henning. Henning, how do you decide when to use fasciotens? And do you see it more as a replacement for component separation or an adjunct? Where do you see it?
Well, I take all the cases with incisional hernias, W3 and loss of domain, and we prepare it with the Botox 4 weeks prior to the operation. And then we are going to do it openly with less open skin incision, only as big as the hernia sac and hernia ring. And well, then I can achieve in 90% of the cases a primary low tension closure, and so I can avoid to perform the component separation, yes. But in other cases, I showed my cases, I talked about the cases where it wasn't possible, where I had to perform the TAR as well, and then we could do it in a combined procedure. It is not a competition, it's an additional tool for us.
Yeah, I have a question for Lars. What is your current indication for the endoscopic anterior component separation, Lars?
First of all, it has to be a midline hernia, and that excludes a big part of the patients. Before the era of Botox, preoperative preparation with Botox, we used it for midline hernias more than 10 centimeters in width. I can also say that many of the patients will do fine just with a unilateral component separation if the diameters is about 10 to 12 centimeters. As I pointed out on one of my last slides, whenever there is lateral scars close to the midline, we would definitely go for a TAR procedure on that side to allow for sufficient mesh overlap so that there will not be a recurrent hernia in a lateral scar.
Any patient with an abdomen component syndrome, the hypertension of
post-operatively?
I mean, not medically. It should be the ideal, the medical indication for a
yes. I have very little experience. Syndrome. We only had 2 patients where we did this on during a period of 8 years, but it was very effective.
So that's a good message.
So it could be done.
Yeah. Yeah.
Victor, now that you've switched over to doing some of these ETEP TARs robotically, what do you think of, what's the future for a laparoscopic ETEP TAR?
Well, I think, honestly, I'm in love with this access, and probably I will never leave, except some very specific indication. For example, a large defect where TAR is necessary to be performed in both sides, I would start directly into the peritoneal cavity. But except also if the defect is located in the lower part of the abdomen, when I can place Dr. Robert under the costal margin, and I can avoid to use 6 trocars. I have to say that the access is difficult, and for me, I consider the most delicate and important and difficult step is crossing over the midline. After you have a large space, it's absolutely the same as in IPOM or into the peritoneal cavity. Using the robot, it probably will be the future because it's much, much easier. And a lot of surgeons can perform difficult surgeries which without the robot is probably impossible.
Yeah, I think that we watch these videos of Victor and Romana and Igor doing laparoscopic TARs, and I, you know, Jorge and I do them as well. But it's such a difficult thing, like we talked about before. What can you get other people to adopt easily? And I think it's just really amazing, beautiful surgery, but it's hard, really hard. And I think that that's, in America at least, we see that's where robotics has exploded. because it allows everybody to do that, because the suturing is what's time intensive, so very Igor Belyansky is supposed to do a randomized trial between robotic and laparoscopic TAR, and he doesn't even want to do the study because he doesn't want to do the laparoscopic cases. So I think that the beauty of, if the robot costs come down and we see that there's a lot of competitors for robots, this is a real benefit of robotics, is to do this kind of ETEP work for ventral hernia.
And having a lot of surgeons who will be able to do these procedures represent a huge advantage for the patients, for the population.
Yeah.
Let me be the devil's advocate for Jan Cucleta. Why the experts use the posterior component separation for even huge hernias without the need for buttocks, and others attribute the benefit of closing midline to the buttocks and the posterior component separation together? So how could we know what is, if it's the Indian or is the arrow in this case?
Well, I think it is just a history of that. It came from Mexico very slowly, actually, only the Spanish-speaking minorities. So you see how the BTA therapy is spread. So it probably for a skilled surgeon, the most logical way after doing open repairs to continue with TAR. And you probably have to start with this first. And then second argument was the off-label therapy. People somehow afraid of the consequences. I've heard a very nice lecture about juridical questions if you do run into off-label therapy and have problems. So there is still some reluctance using this agent. And PPP, exactly the same. Actually, there are very few countries that cultivated this. Argentina, Spain, among others, but the rest actually refrained. How many of you have ever done a progressive pneumoperitoneum here? Wally? Yes, clear? Mark Miseres, and that's all? Representing Europe. Oh, free. And India.
Johan, I have a question for you with PPP. Have you had any problems with DVT and PEs or with clotting problems? Do you regularly anticoagulate your patients? You put them on Lovenox when you do PPP?
I didn't understand the question. Is that if I have problem during performing the PPP?
No. There's been reports of people having pulmonary embolism, right, with PPP, or having clotting problems, right? Do you put your patients on Lovenox blood thinners when you do PPP, or you don't worry about it?
I don't understand. Because as an American, you speak too fast for me. Can you repeat?
Embolism, yeah.
The question is, I have some problem during the PPP procedure. Is that your question?
No. Prophylaxis.
Prophylaxis.
For embolism.
No prophylaxis. No, because the patient has to run, the patient has to walk, the patient has to... I say always, with 15 meters, you have to step 3 stairs with me before the operation. If you don't do that, I don't operate you. And we do that, and it's okay. With 15 liters, they are able to do that. So I say you don't have to be on your bed or watching TV. It's not possible. You have to walk, and so that's it. Yeah. So no prophylaxis for me. And I never had any problem.
The French smoke so much, then they're prehabilitated for PPP. Yeah.
We have had some severe complication regarding pneumoperitoneum, just the contrary to the Botox. With the Botox, I think we have been using for the last 5 years. We have the impression that we can close more than after posterior component separation and less pain. That just has been also pointed out by Jan Cucleta. But I think PPP, we have had severe complication. We have had pneumomediastinum. We have had deep vein thrombosis in the leg. We have also seen hematoma, the rectus abdominis muscle. We have also seen a cardiac arrest after insufflation of the pneumoperitoneum. So, So I like to insufflate and admit it in the hospital because of the potential risks. I think it's not risk-free at all. The pneumoperitoneum is a risky procedure and should be, I think that the main thing is that what, Johan, you have shown us in your slide, that should be clearly indicated, no? But I think it has a clear indication, of course, to use PPPP.
Yeah.
Yes, I agree with you. I don't know if the question was the prophylaxis, but I had the same problems. I think 1 month ago, I had a patient with complete hemiplegia because he had air embolism in the brain, and it's horrible, you know. And it was not a puncture, it was a portocat. So I think, I don't know, because of the pressure, a vein opened and the air go through, and he had a permeable
PFO.
FOP, and it was a brain embolism. So the patient was not didn't die, but actually is complete hemiplegia.
Yeah, I think that in the United States, PPP has less usage because of the fear of this. That you know, I'm always impressed that you show that you do it right in the clinic. You know, that right at the bedside, and the patients just jump off the table. But in the U.S., I think there's a lot of fear. You admit the patient to the hospital, you do it in the operating room, you keep them there and put them on blood thinners. But it's, you know, clearly you can do it safely. But we worry about this because there's a few cases of people that have pulmonary embolism and die. You know, so that's, even though it's a small frequency, that's a little bit scary.
No, there is not so much complication, but when we have the complication, it's always a big complication.
Yeah. Henry?
Maybe one last question to Lars. Lars, isn't it easier to do the laparotomy first? It's not working, I guess. That works. Sorry. Isn't it easier when you do your endoscopic anterior component separation to do the laparotomy first, to have a little bit more of control, especially at the beginning where you are? Because I was in your course, and it happened to me twice that I went into the wrong plane and I was suddenly retrorectus, and then I had to pull back, and this is maybe preventable when you do the laparotomy first. And also, because sometimes we don't know if it's necessary at all. So you can do your retromuscular dissection, get a feeling about the tension, and then you can decide if you do or do not need an anterior component separation.
It's a good question. In the early era, before Botox, we knew pretty well which kind of patient it was definitely required, and I'm talking about defects larger than 12 centimeters. It also, of course, depends on the width of the rectus muscles. So actually, most of our patients, we started using this procedure before the laparotomy. I get your point. If the patient has received Botox 4 weeks ahead, you might be able to close the patient without the use of additional component separation. And in that case, you evaluate it during surgery. If you have to do anterior component separation by the endoscopic technique, there should be some kind of traction on the divided midline, allowing easier dissection laterally. But it's a good point, and I would advocate just to evaluate, because the effect of Botox treatment is so variable between patients in our hands.
Miguel, I have a question for you. You know, so every time I watch you do the Madrid modification, I think it's such a fine, beautiful surgery because you really follow the muscle. It's such an anatomic operation. I love it. You reattach the transversus abdominis to the mesh. Do you find that improves the shape afterwards, that it prevents the bulging that we see when people have posterior component separation? Or what do you find is the difference then?
That's a good question. We are now studying differences in the CT scan, the displacement. We have not finished this study yet, comparing conventional TAR with our modification. But I think that, of course, I wouldn't do it in a 70-something years old man who's not physically active at all. So probably I will reserve this reimplantation for younger patients. But we have had to make abdominal wall reconstruction in very young patients, also practicing sports, and I think that it may make sense to give immediate function to the muscle immediately after the procedure. That's the reason. It's there, and it's easier. And One of the tricky things is not to try not to injure the neurovascular bundles that are quite near your suture there, and not to make too much tension, of course, just restore the continuity of the posterior abdominal wall.
I would have a question for Jorge Dice. You published, sometimes it turns. No, you published something about comparing the anterior component separation with the posterior ones after 4 years or 5 years, and showed how the gap after posterior, after TAR, was a very, very little. So there was not actually nothing that you would have to adapt or fix to the mesh. But after the anterior component separation, the gap was over 4 or 5 centimeters.
That's a great question for Miguel, because, that's our findings. The displacement of the TA was only evident in one of the cuts at the level of the superior mesenteric artery. I was only 0.8 millimeters, so 0.8 centimeters. That was all. And there was no change in the shape or the circumference of the abdomen, and it was improvement in the thickness of the lateral muscles. So the question would be why to modify that with these findings? So we have to study a comparison between the two, probably, yes.
We have a question from the audience back there. That's the...
Hello. My question is for you that how do you manage weight loss? Because weight loss is an important factor in optimization. And which is the time frame from your first consultation to the surgery? Which is the time frame that you give to the patient to lose weight? And if he doesn't manage to do it, then you still operate, or what is your technique with this?
Why don't we go down from the end and talk about what's your BMI cutoff?
My BMI cutoff is 35, and I wait until the patient reach the objective. It is 3 years, 5 years, no problem.
So the objective is 35 as well, but we cannot wait so long because people are getting complication prior to the operation, and if they do so, you have to perform the operation even without the prehabilitation. That's our line.
Well, my answer would be exactly the same, 35, and limited by the possibility of strangulation.
Yes, quite similar. I try to encourage lose weight, but I will make it if the patient cannot lose weight, because some patients, because of the condition of the defect, because they cannot walk anymore, they cannot, the quality of life is completely impaired and they cannot really lose weight. So in younger patients, we are considering obesity surgery before the incisional hernia repair in younger patients, but we try to encourage, but I don't ban the procedure if the patient cannot lose weight, because some patients cannot lose weight anymore. And so the risk of an emergency operation is so high.
So 35 also, or
yes.
What?
Same in our institution, we are very strict about the BMI less than 35. I would add, our bariatric surgeons are very reluctant to operate on these patients. Some of them may have a chance with a gastric sleeve. I think bypass is excluded as an option because of the hernia. I think the future are these new anti-diabetic drugs that they are administered once a week subcutaneously, and they are nearly as efficient as bariatric surgery.
Yeah.
So I think perhaps that's the way to go.
Yeah, well, for me, for the patients in the same condition as Miguel said, who are not able to lose weight, the limit is 40. But of course, it's better to lose weight before. So regularly it's 35.
Yeah, and I think the data, if you look at the data, Yuri Novitsky shows that BMI of 34 all of your risk normalizes, you know, so, but at 34, it shoots up, so then, and then at 40, it becomes prohibitive. So I think that that's why we all say 34, 35 is what you want them to do. But it all depends on symptoms, that if they have to have surgery, then you accept higher risk, you know, so, but at 40, then we start thinking about minimally invasive techniques, you know, doing ETEP, doing robotics, and then you can minimize some of that risk as well. What we find is that even at a BMI of 40, if you do these surgeries, you can get rid of a lot of the wound complications if you then, that's probably a benefit of robotics. Okay, we're gonna have a coffee break.